Thank you, Congressman Dold and Air 340B, for your support of today's conversations. And now, please welcome our panelists in conversation again with Bob Cusack, Editor-in-Chief of The Hill, Dr. Elena Rios, President and CEO of the National Hispanic Medical Association, Avik Roy, President of the Foundation for Research on Equal Opportunity, Dr. Gary Puckrein, Founding President and CEO of the National Minority Quality Forum, and joining us virtually from Baltimore, Dr. Leana Wen, Emergency Room Physician and Professor of Health Policy and Management at the George Washington University.
Thanks, and thanks for joining us, panelists. Leana Wen, see you on TV all the time, so now looking at another screen. I'm gonna start with you. What on specifically access to care? What have we learned from the COVID-19 pandemic?
Well, first of all, wonderful to join you all today. I'm sorry that I can't be there with you in person, as I actually have my childcare this morning and unfortunately have to get to clinic immediately after this. So I think we've learned a lot from COVID about access. And I think we've seen how disparities are not new to COVID, but certainly were unveiled and unmasked during the pandemic. But I actually also just wanted to share some thoughts about the issue of access from my experience as a practicing clinician here. I work, one of my clinical sites is here in Baltimore for a clinic for underinsured and uninsured patients. And when we think about access, I think initially there's a focus on cost, which absolutely we need to talk about the cost of prescription drugs. We need to talk about the cost of healthcare, the cost of insurance, and so forth. But I think we also have to consider the other conditions in people's lives. I mean, so many of the patients I see, especially when it comes to chronic medical issues, for them, health is not at the top of their priority list because they have so much else that is going on in their lives. They're managing their children, their grandchildren, their parents, they're working multiple jobs. And a lot of times they may be running out of medications or not filling their meds, or not even knowing that they have run out, simply because there are so many other issues that are at the top of their attention list, and they have not gotten to the issues pertaining to chronic illnesses in particular. And so I think closely related to this is the issue of addiction and mental health, that individuals with behavioral health concerns are not getting those attended to, and those issues then further exacerbate underlying physical health disparities as well. And so I hope that we'll be able to discuss all of these issues in some way today, understanding that that, as you were saying in your question, that COVID certainly unmasked and helped us to see some of these disparities firsthand, but they have existed well before and are going to exist well after the state of emergency around COVID ends.
Dr. Rios, as far as one thing, healthcare is such a vast field, but what do you think policymakers, whether it's federal or state, need to invest more or focus on more that they're really not focusing on now?
Well, I think when the Affordable Care Act was passed, part of the Affordable Care Act that needs to be discussed again is public health. And public health, the infrastructure, as well as the ability to use a public health system that works to get to the community. So in our community, in the Latino community, most people aren't insured. There's still a large group of people, whether they're poor and work for small employers or are immigrants, what you name it. There's a lot of people that don't have insurance, which means they don't have let's say they just don't think about going to the doctor unless they have an emergency. And so for us, healthcare information and education needs to go through public health, or needs to go to the community, with the churches, with the grocery stores, with the institutions in our communities where people can get information. And I think that's something that needs to be discussed again, and as well as what Dr. Wen said about mental health. It's so important that we have so much mental health issues because of chronic stress, because of not only chronic diseases, but the issue of the social determinants in our communities. We have drive-by shootings, gangs, people that are accosted just walking down the street, can't even walk safe in some of our neighborhoods. And I think that causes more anxiety and toxic stress in our families. So There's just so much that needs to be done.
Looking at COVID has been such a difficult time for so many people. I think we all know people who've lost their lives from COVID. But it seems like one silver lining, and you mentioned mental health, so I wanted to follow up on that, is people seem to be more open to talk about mental health issues. Is that one of the silver linings you see, and do you think that'll continue? Because it still is a stigma, but I think it's less of a stigma than it used to be.
I have to agree that people want to get more care, but where do they go for care? We need more training of younger people with, let's say, connected to STEM. The Department of Education always focuses on K through 12 and doesn't think about careers. HRSA gives money to the medical schools, to only the few that get into medical school. So there's got to be a connection between education and career development for the STEM students in our country that are science and math, that have science and math abilities to be able to go on into medical school and get into psychiatry, or to become social workers. You don't have to be STEM, but to become social workers and professionals to deal with the problems in our communities, I think is important that we do that.
Avik, Roy, I want to talk about health equity and the system, the healthcare system we have now. You would not devise, but we are where we are. I remember when I covered healthcare, Ways and Means Chairman at the time, Bill Thomas, floated the idea of decoupling employment and healthcare coverage because it just doesn't really make sense. You lose your job, you lose your healthcare. But that was very politically difficult to do and was not done. And so it comes down to, when you're talking about health equity, you're talking about the price of healthcare. Where are we and where are we going on health equity?
Well, Bob, thank you for asking that question. First, I want to talk about this COVID piece just for a minute, because I think one thing that we have not yet learned or not yet fully appreciated about our experience with COVID is how much our response to COVID worsened disparities. So when you have economic restrictions that people like us who work off our laptops have no problem with, but people who work with their hands, a bartender, an assembly line worker, they're the ones who face the consequences of that. The school closures, which were not necessary, or could have been adjusted a lot better to balance public safety and education for kids. Now, often say, oh gosh, there's all these learning losses that we now have to contend with. We knew this all the way through. Other countries had reopened schools and safely done so. We didn't learn those lessons until it was much too late. So I think we're only now beginning to contend with the disparities that our response to COVID created that are really important for us to focus on over the next several years. Now, you mentioned a great point, which is that not only is our healthcare system obviously inherently regressive in certain ways, but the most important and most regressive piece of it has to do with the tax code. It's the fact that we've excluded from taxation employer-sponsored insurance benefits, group insurance, which has driven all sorts of inflation, as everyone who does healthcare for a living knows. And I think one thing that there's a ray of light in this area. So it's been a very hard thing to reform, as we've all known, as particularly those who've worked in Congress. But there's a ray of light, which is that there's this new rule that came out of the Trump administration that allows health reimbursement accounts to be deployed to purchase individual insurance. So it used to be the only way you could take advantage of the tax benefit from employer-sponsored coverage is if your employer bought the coverage for you and for your entire group. Now there's an opportunity for employers to say, you know what, we're going to give you $5,000, $10,000, whatever the employer wants to give, in a health reimbursement account that's also tax-free, but that allows you to shop for the coverage that you want on the ACA exchanges. And so that is a model paired with other reforms that strengthen and build on the exchanges, could, over time, really allow for that individual choice so that people aren't just handed a piece of paper from their employer, but actually have multiple options. And that's profound because it incentivizes the insurers to compete for workers' business. Say, you know what, I'm going to take a tougher line with the hospitals. I'm going to take a tougher line with the drug companies so that you have a lower premium, so you choose my insurance plan. And that creates a lot of downstream benefits that we're not seeing today because the patient, the consumer, is a total passive participant in this process.
Gary, National Minority Equality Forum has some new poll findings out this morning. Can you tell us a little bit about it?
I certainly will, but before I just talk about the poll, I want to help us reset this conversation a little bit, right? Because I don't think we're always being honest with ourselves when we're talking about healthcare. we're always about healthcare for ourselves, right? I don't think anybody in this room would go into a healthcare system with the expectation that they're not going to get optimum care out of that healthcare. So the conversation is really about healthcare for our neighbor. What we're arguing about is whether I want to provide healthcare for our neighbor. And the point of the matter is that in this democracy, we promise collectively to work together. In fact, it's life, liberty, and the pursuit of happiness, life being the first one. And so I think if we start with an honest conversation about, I'm really having a conversation about the access to healthcare that I'd like my neighbor to have, because I know what I want, right? But I want to talk about what my neighbor has. And the minute you do that, you come to the question of, do we actually value life? Do we actually value our neighbor's life, right? Because if you don't give access to healthcare, you are putting that life at risk, right? You may go through your legislator or whoever, the proxy that you have, but the point of the matter is you've made the decision that the life of your neighbor is less valuable to you. And so when we have these conversations about access, about drug pricing, all of those conversations are really about what would I like my neighbor to have. Unfortunately for the African American community and Hispanic community, because we quote unquote have been minorities in the population, the majority has in effect said that we're going to limit access to health care for you. And that's what disparities are about. They're about the fact that the healthcare system is denying access to quality health care. And you can look at the numbers. We don't have to have an argument about fact because the facts are very, very clear that they're not getting access to quality health care. And so we started to reach out to the minority community through polls, and we'd love to continue to do that because their voice needs to be heard in this conversation, right? Because it is a collaborative. Healthcare is a deep collaborative. And when we go and we talk to minority populations about things like drug prices and other things, it's not a monolith, right? There are some who support government interventions, and there are some who do not. But from the NMQF perspective, from the National Minority Communities perspective, we have to provide optimum health care to everyone who comes through the door. We cannot give ourselves permission to deny quality health care to anyone, right? Because that invalidates the collective promise that we made to each other when we formed this government, that we would take care of each other. And healthcare is definitely a part of that. So what you're going to see in the polls that we're putting forward is that you're going to hear the voice of minorities for the first time because they have not had access to things like polls that actually tell you what they're thinking and feeling about healthcare. But at the end of the day, we cannot give ourselves permission to deny our neighbor access to quality health care. That is a complete violation of our commitment to each other.
And the poll.
Mm-hmm. And the poll.
What did your poll find?
Our poll find that minority populations, African Americans and Hispanics, are concerned about government setting prices, right? In no place else in our economy, any place, do we think it's a good idea for government to set prices. And there's a whole historic reason for that. If you go back to the Nixon administration, right? The Nixon administration tried to set prices, and it led to stagflation, right? Because the marketplace reacts to the fact of government setting prices. And the other point that was being made here that's incredibly important is that the healthcare system has to be consumer facing. It can't be government facing because government becomes the client in that instance. What we want is a healthcare system that's valuing every life when it wakes up in the morning and is concerned about reacting to that consumer. And the only way that can happen is that it has to be consumer facing. And you cannot have a healthcare system, I would argue, that is going to deliver quality care if government is going to set value. And that's what pricing is. It's government setting value, and that's really not a good idea.
I would love to say a couple things in response to that. First, I think broadly, it's not just minorities who want every American to have access to good health care. I think all Americans want that. Polls show overwhelmingly that the overwhelming majority of Americans want a system in which everybody has a fair shot at good access to health care, the basic financial security. We all want that. We may disagree about how to achieve it. There's obviously a lot of blockers to make it possible, but I think that's a widely held aspiration. It's not just a minority aspiration. That's number one. Number two, on the point of prices, it's ideally you'd have a system in which people, just like in the rest of the economy, compete for your business, and that's how prices are set. But in parts of the country where, say, there's like in Connecticut, where I went to medical school, Yale New Haven Hospital Health System owns the entire state. There is no competition, right? So in many parts of the country, there's become massive consolidation with hospitals. In drugs, there's not monopolies just because of patents, but also because of other things that Congress and the FDA have done to create artificial monopolies. When you have a monopoly, you can't have the competition. So then what do you do? And I think that's a tougher problem for just let the market figure it out idea. You either have to create the competition, which I would certainly prefer as a free market advocate, or you have to do something to regulate monopoly exploitation of their status.
I'm all about competition. That's the American way. We compete in the marketplace every day. I think that's a great idea. And the challenge has been, when government came into the marketplace in healthcare in 1965, it promised that it wasn't going to set prices. If you go back and listen to that conversation that went on in Congress and with President Johnson, the idea was government was not going to come in and set prices, that it was going to let the marketplace compete. I'm for competition. Right? Now, obviously, it's not a free-for-all competition. You have to set boundaries for sure, and government should be that referee, setting boundaries, but it shouldn't get on the field and play baseball, right? It shouldn't be down there on the field calling balls or strikes, batting, pitching. I mean, that doesn't work. So I think good competition in the marketplace is a great idea, and we want to figure out how to free up the market in healthcare so it works.
Leana, I want to get your opinion on monkeypox, which is such a huge issue, and especially in D.C., the highest per capita rate now across the country. Where are we, and where are we going? It just seems like the news keeps getting worse.
Well, I just wrote a column in today's Post about this, and I think there are two things that are simultaneously true. One is that most Americans do not need to worry about monkeypox yet, as in this is not something that people should think about changing their daily lives or rushing out to try to get a vaccine. Most people, obviously there are some who are particularly vulnerable. If you're in the community of gay, bisexual men who have sex with men, with multiple or anonymous sex partners, a very different story. This is the population most at risk. But most people don't have to change their lives yet. At the same time, there needs to be a public health response, because for us to turn a blind eye to monkeypox and think that it's something that's going to stay within one population or will not affect us in the future, I hope we've learned by now that infectious illnesses don't stay in one group. And in fact, that this is a threat that really needs to be contained. And I think it would say a lot about our lack of a public health system if we're unable to contain this, given that we have known about monkeypox for decades. This is not like COVID, which was a very rapidly spreading novel coronavirus, respiratory virus, spreading easily from person to person. Monkeypox is spread through direct, prolonged, intimate contact with someone. There's also a vaccine that's already available that can be given to people after exposure to prevent them from developing the illness. And so there's every opportunity for us to contain monkeypox. And I think these two things can both be true at the same time, that most individuals do not need to yet worry about monkeypox, yet health officials need to do a lot more. And from that standpoint, yes, we need to get more vaccines out. I think we also have to focus on testing, because if it's anything that we've learned from COVID as well, it's that if we don't test, we're not counting cases. And I suspect that there are a lot more cases that we're not yet testing for. We don't yet know the degree of asymptomatic transmission that may or may not be occurring. And we have to do a lot more in terms of reaching out to individuals and identifying them so that we can break the chains of transmission.
Dr. Rios, I wanted to ask you about telehealth as far as access to care. I was talking to Dr. Burgess before from Texas, and he says we're not going back. mentioned pending legislation on this. Now, at the same time, not everybody has high-speed internet across the country.
Right.
So is that something that has been, you think, should continue? And what are the other obstacles that you see, outside the Beltway that maybe Beltway people need to focus on?
I think we are going to have to continue telehealth, and I did appreciate the Congressman's support for continuing, the laws that are being discussed right now for the next 2 years, and to actually make it more standardized. But I do think that communication with people that do not have access to internet is going to be important. Most people have a cell phone, and texting has been shown. The HRSA's maternal child health programs have used texting for a long time, and I think that that has to be included too, not just video screen, computer, intranet.
Mm-hmm. Avik, as you've advised Republican presidential candidates. I was talking to Congressman Burgess about the likelihood the House is going to flip. The Senate is kind of more of a jump ball. But regardless, what should be the Republican agenda in 2023 if they have the House and/or Senate?
There's actually a comprehensive health reform bill that a number of Republicans have introduced, both in the House and the Senate, called the Fair Care Act, that strives to achieve universal coverage using private insurance. Obviously, the public system is still there, but it fills in a lot of the gaps and tries to tackle the cost problem in both, particularly hospital care and drug pricing, and does a really nice job of means testing. The way we help people afford health insurance right now, as we talked about earlier, we have this employer-based system in which you get a bigger tax benefit if you're in a higher tax bracket. So you're wealthier, you're a lawyer, you're an investment banker, you get a bigger subsidy from the government to buy health insurance. The Fair Care Act would fix that, so you get a standard deduction and use the savings to help fill in some of those gaps in health insurance and the uninsured population. So it's a very interesting bill. I think what's happened is that because Democrats have had the House and the Senate and the White House, there hasn't really been an incentive to work with Republicans, right? The incentive has been more, sure, let's just do what we can do on our own and leave the Republicans out of it, which, I understand that as a political point of view. But if Republicans control one or both of the houses of Congress, then it becomes there becomes a bigger opportunity to try to build bridges, right? To work on some of the other ideas that may have bipartisan support. So I think that, to me, is the opportunity. Now, there is, of course, the various task forces that Kevin McCarthy has set up, and including one on health care. To me, the what they're working on that front is relatively like the low-hanging fruit, things that aren't going to put a target on their backs and jeopardize their ability to win in November. Which, again, I understand from a political standpoint, but my hope is, and certainly what I'm advocating for is, once you get through November, whatever the result is, let's find ways to work together and solve some of these big problems. They can increase health equity, but also solve the sustainability problem of our healthcare system. Because at the end of the day, I have young children. We're not going to have a healthcare system if we keep going the way we're going with a $30 trillion, $50 trillion, $70 trillion debt in the future.
As you know, politically, if the House does flip, you're going to have freshman members who are going to want to vote on repealing Obamacare. If you had a magic wand, should that fight be over now? The Supreme Court has spoken, or obviously, Joe Biden is not going to sign any bill into law, so it's going to be divided government. Do you think Republicans should move on from that, or are they going to have to do it politically because the new majority members will want to vote on it?
I actually think it's the exact opposite. In my experience, the experience of our team, the people who are the most interested in moving on from the fights of the 2010s and actually solving some of these big problems of affordability and uninsurance are the freshmen, are the younger members who are not tied into the battles of the past and actually say, you know what, I came to Congress to solve problems. My constituents can't afford their health insurance. Their deductibles are going up. Their premiums are going up. They're struggling. Inflation in general is a problem in this country, but healthcare inflation has been a problem for a very long time. That's not a new phenomenon. And these members know that. And so I think what you're seeing is a real opportunity or a real window where a lot of these new Republican members saying, hey, I want to tackle costs. Take Jim Banks. So Jim Banks is a third or fourth term congressman from Indiana, heads the Republican Study Committee, which is the most important Republican conservative caucus in the House. he has sponsored the Hospital Competition Act based on a lot of our work at FREOP on hospital competition, which really does an effective job at trying to tackle a lot of these problems around the anti-competitive practices of consolidated hospital systems. So there is a lot of leadership coming out of these younger members that I think you'll continue to see in November, after November.
Gary, I want to close with you as far as programs that maybe work at the local level or state programs that you think federal policymakers should look at, because the states have their own healthcare systems and Medicaid, and it's kind of an alphabet soup of government agencies running them. But if you had a kind of a magic wand, what do you think should be a model for healthcare moving forward?
Well, that is one huge question, right? And so you have to figure out which part of that elephant do you want to bite on. I think where I would start really, so Medicare is a disaster. Let's all agree to that. We've got 90 million Americans in a healthcare system that is a prisoner to state budgets. And somehow we've got to fix that monster because they're not going to get quality healthcare. But from a clinical standpoint, if I'm just thinking clinically, how do I want to improve the health of the American population? I would start with data. We have to unlock health data in this country. We can get very, very smart very, very quickly. COVID taught us that we can build the plane and fly it simultaneously, meaning we should be able to tackle diabetes as a national emergency, right? This is a raging epidemic in our country. And we could use the methodologies that we developed with COVID, where we find innovative therapies and we figure out how to get them to the American population as quickly as possible. There's tremendous work going on in cancer with these liquid biopsies that are coming on, that are diagnosing 50 cancers at one time and finding people who have cancer before they're symptomatic. Think about that. Before you're symptomatic, we'll be able to treat you for cancer. What's broken is our healthcare financing system. It is archaic. Right? It is a complete broken mess. And so I would start building that data system so we can move the data, and then we've got to sit down around the table and have a real conversation about healthcare financing because we are not going to take advantage of all that wonderful innovation that's available to us in the current system. It's just not going to work.
We have run out of time. I want to thank our panelists, Gary Puckrein, founding president and CEO of National Minority Equality Forum, Dr. Elena Rios, President and CEO of the National Hispanic Medical Association, Avik Roy, President of the Foundation for Research on Equal Opportunity, and Dr. Leana Wen, Emergency Physician and Professor of Health Policy and Management at George Washington University. That brings us to the end of our program. On behalf of The Hill and our sponsor, Air 340B, we'd like to thank everyone who joined us here today. And if you missed any portion of today's discussion, the full video will be available on thehill.com. Thank you so much. Appreciate you joining us today.
Great.
Thanks, Bob.
Thank you. Hey,
Thank you.
Great.